Thank you for joining our webinar. I'm Dr. Lata McGinn, here today as the president of the World Confederation of CBT, otherwise known as the WCCBT. Before I introduce Dr. James Underhill and the webinar, let me begin by sharing what the WCCBT is and why we are here today. The World Confederation of CBT is a global multidisciplinary organization comprised of 6 regional associations, ABCT and CACBT representing North America, EABCT representing Europe, ALAMOC representing Latin America, AACBT and ANZA-CBT representing Australasia, ACBTA representing Asia, and the IACBT. Broadly, the mission of the WCCBT is to promote and advocate for global mental health and to facilitate the development and dissemination of evidence-based practice through the formation, collaborations, and partnerships with organizations. The key priorities over the next 3 years of my presidency are to support the dissemination of CBT in underserved areas, particularly in Africa, disseminate our training guidelines globally, and to partner with organizations such as the World Health Organization and governments on disseminating competently delivered CBT. I'm delighted to let you know that the WCCBT signed an agreement with the World Health Organization in November of this year so that the WCCBT and the WHO can collaborate on common initiatives to increase CBT competency and to disseminate evidence-based practice across the globe, particularly in underserved areas. We are delighted to have Dr. James Underhill here to present to us. Dr. Underhill is a clinical psychologist and the project coordinator of the Ensuring Quality in Psychological Support project, which is part of the WHO's Department of Mental Health and Substance Use. Dr. Underhill also supports the department with its work on scalable psychological interventions and digital mental health. He has extensive experience in clinical and humanitarian work, creating and developing innovative services for trauma and GBV survivors, refugee populations, and adolescents involved in serious youth violence. In his role as EQUIP coordinator, Dr. Underhill has been centrally involved in the development and public release of the EQUIP digital platform, which is part of a joint WHO-UNICEF project to improve the competency of helpers and the consistency and quality of training in psychological interventions and service delivery. He's here today to talk about the work of the WHO on psychological interventions broadly, and specifically about the EQUIP program, which is the WHO's effort to standardize competency of both specialists and non-specialists in their provision of mental health services. The EQUIP program is an initiative with a suite of easy-to-use competency assessment tools in standardized role plays and a digital platform for providing real-time visualizations and feedback to improve training and supervision. In this webinar, Dr. Underhill will introduce their work on psychological interventions, and he will introduce EQUIP and provide examples of its use in various contexts and sectors, including in pre-service education settings. So without further ado, please, I invite Dr. James Underhill to begin.
Thank you, Lata. And thank you everyone for, well, thank you Lata and for the WCCBT for inviting me to speak today. And thank you everyone for finding time to attend the webinar today as well. It's really great to see so many of you interested in the work of the World Health Organization. I'll share my screen so as I can share my slides. I've kind of extended what I'm going to talk about somewhat, to talk a bit more about scalable psychological interventions and our work on that, as well as the project, as Dr. McGinn has said, on the EQUIP project that I'm more centrally involved in. So I've given us quite a long title today, but hopefully we can get through everything. I should say that as I go through, I may go through quite quickly because I want to give space for questions at the end as well. But we will be putting up links to various different websites, products that I'm talking about as well, in which there's a lot more information. Also, please do feel free to get in touch with me, and my email address can be circulated as well in the chat, I hope, to comment on anything that I present today or ask any further questions, or if you're interested in finding out more. So to start off, I'm going to set the scene broadly, I think, and just talk about where we're at globally around mental health. And a lot of what I'm going to talk about here comes from a publication that was published, was it this year, May, or the previous year, May? I can't remember, which is really awful of me, and it shows how my years are rolling into one. But very recently, WHO produced the World Mental Health Report, which I actually think is an excellent document, and I recommend everyone reading it. It's freely available. Rachel should be able to put a link to the document in the chat. And I'm going to talk very briefly about some of the figures here, but it covers a lot of what I'm going to talk about as well. So what's discussed in that report is where we're at in terms of the epidemiology around mental health. And what we know is that mental health needs are very high. I'm not going to go into this in depth because I don't really have the time, but we're looking, a lot of these figures came from before COVID, just under 1 billion people living with a mental health disorder. I think with COVID, where we saw rates of anxiety and depression increase by 25%. We're seeing a number of people dying by suicide. We're seeing years lived with disability, mental health accounting for quite a sizable proportion of that. What we also know is, in terms of trying to reduce this gap, to try and address this need, that there are a number of different gaps that exist. So we have research that still needs to be done. We still need to think about the policies that are in place to ensure that we're treating people with mental health conditions with the rights that they deserve. Obviously, resources is a big issue. I think on average, 2% of countries' health budget goes to mental health, but in many countries, particularly in low and middle income countries, that's a lot smaller. Then if we think about the services that are on offer for people with mental health conditions, most people, many, go untreated. Services are unavailable, inaccessible, many places unaffordable, and of low quality. And what we're seeing in low and middle income countries, that only around 3% of people, for example, with depression, are receiving what we might consider minimally adequate care. So the needs are high, and the work that needs to be done to meet those needs is sizable as well. I guess I wanted to put that in context of this idea of universal health coverage. That's something that we at WHO are working towards, and actually something that essentially every member state has also signed up to as part of the Sustainable Development Goals. And when we talk about universal health coverage, we're talking about everyone everywhere having the healthcare they need without suffering financial hardship. So it's not saying free healthcare for all, but it's saying that healthcare is there and it's accessible. And it has been laid out very clearly that mental health needs to be a part of this universal health coverage. And I think very importantly for what I want to talk about today, but I also think for what I'm assuming many of the members here are also interested in, is that we need to really work with people and build the competence of people to be able to work with mental health needs. And that's not just psychologists, that's a really broad range of people who interface with those who are asking for help. So yeah, I just wanted to lay that out as I guess the context within which I'm going to talk. So within the mental health and substance use department in WHO, we're obviously working on a number of different areas. I really focus on this idea of scalable psychological interventions, for which over the past 20 years or so, we've really seen a growing evidence base that these can be effective when culturally adapted, which is a really important point, I think. And that these interventions can be delivered by non-specialists. So that's kind of our starting point, that if we're really going to meet the needs of people, we do need to think about a broader range of people who can deliver these interventions, which isn't to say, I don't think, that a lot of what I'm going to talk about here isn't helpful in the training of specialists as well, or even for those who are practicing. But that's our starting point, that if we're going to meet those enormous needs that I've already covered, we really need to think about a broader mix of staffing that's going to be able to meet that need as well. that these scalable psychological interventions are effective not just for kind of mild or perhaps what might be considered more simple problems, but for those more severe emotional problems as well. And when we're thinking about scalable psychological interventions, what we're thinking about is how they can be delivered differently. So can we use lay people? Can we use IT in some way? Can we use self-help materials in some way or another? We're thinking very much about transdiagnostic approaches as well, and where a diagnostics assessment isn't necessarily needed in their delivery, and to make the delivery of these interventions quite brief, and really focused on the skills one needs for managing themselves, essentially. So at WHO, we've taken this idea of scalable psychological interventions, and we've seen that there's quite a lot out there, but also a lot of it isn't open access. It's very hard for people to reach, to be trained in, etc. So we've worked to develop a number of different scalable psychological interventions that we then release open access, so that can be freely used, freely adapted. All of these materials I'm going to talk about are published on what's called a Creative Commons license. So anyone can take it, remove WHO's logo and adapt it, change it in any way that they want. We're also publishing a number of training. We're in the process actually of developing the materials for the training in these interventions as well. So I'm just going to talk about a few of these interventions. If Rachel maybe can put up the link to our website that has all the links to all of these interventions and more that you're free to access and free to use. So the first thing I'm going to talk about is Self-Help Plus, which is essentially a group-based stress management course. So you can run it with quite large numbers of groups. It uses audio recordings, actually, that means you can have quite minimally trained facilitators who can deliver this intervention with quite a lot of consistency. It's based on the concepts of acceptance and commitment therapy. And we've now made it available in a number of different languages, and we're having more and more languages added. If people are interested in doing translations, we can support translation as well. And as with all of our interventions, we don't publicly release these until we've kind of set ourselves the arbitrary target of 2 positive randomized controlled trials in 2 different contexts. So Self-Help Plus actually has now quite a bit of evidence behind it. There's also been quite widespread implementation of this. For example, in Ukraine, post the crisis that's been going there, we've done wide-scale training, and it's become a really key part of the mental health response there. Related to that is a book called Doing What Matters in Times of Stress. So this is very much based on the same concepts in the Self-Help Plus course, but released as a self-help book that can also be run as guided self-help book. This is available in a number of different languages, and we're constantly having people translate this into new languages. We have been working recently, I've been working recently on a study across Europe looking at how this can be adapted into a web-based application and run as a kind of 5-session course with 15-minute guided support from a trained facilitator. And what we've really, and that's with groups, so it's with health and care workers and with refugee and migrant groups as well across Europe, particularly in response to COVID. We were looking at it as part of a step care trial. And what we're really finding is that it can be very effective and easily accessible for people to use. Another perhaps older intervention that has, I'd say, some of our biggest body of research behind it is Problem Management Plus, which is also released as a group intervention as well. It's a kind of problem-solving intervention, really, with a bit of added stress management, behavioral activation in there as well. It's to be done face-to-face, or it can be done, people have used it remotely, so delivering it over Zoom as well. Has now multiple randomized controlled trials showing how positive its effects are. And there have been whole journals, I think, released covering different people's implementations of PM Plus as well. In that trial I talked about before, the step care trial, we used the Doing What Matters in Times of Stress. as the first step, and then the second step being the problem management plus that someone was stepped up to if they scored above a certain score on the Kessler scale. And then just release, actually, I need to change this slide. It's not due for release. It was literally released, I think, early this week, is Early Adolescent Skills for Emotions, which is for adolescents. Really based on the concepts of problem management plus, but adapted for adolescents, and includes sessions with caregivers as well to be delivered as a group intervention. Again, 2 RCTs have now been completed showing its positive effects. So that's just a broad overview. We have other interventions out there as well. I encourage you to please take a look at the website. When we're looking at these interventions and why we've developed them, we're thinking about how the mix of them can support one another, I guess. So some of these require lower resources, some of them require higher resources. So, for example, the Doing What Matters in Time to Stress booklet can be handed out purely as a self-help intervention. We know it's more effective if it's guided, but it can be used in that way. Then we move up to things that perhaps require a bit more resources. So if you're running the group self-help plus intervention, you need to train your facilitators more. You need perhaps a place to host the groups, etc., etc. Then we move on to perhaps individual multi-session interventions, and then moving up to more specialist delivered interventions. And our idea here is that they can be part of what we're really thinking about, a kind of stepped care model. So we're trying to think about the systems we can put in place to really support people and help people to access the psychological interventions, the mental health care that they need. So as I've said, often we would use something very brief as a first step, and then step someone up to something more significant, or onto perhaps specialized psychological care. And the point here isn't that we're reducing the need for specialists, it's that actually we're trying to make best use of that specialist resource that exists. So making sure that we can really direct that at those that need it most and need that specialist care, the thinking and the diversity of approaches that a specialist can bring. And what we've seen, I think, across a number of different contexts, that this really strengthens a mental health care system. So all of this is where we're at now, and what I'm going to talk about with Equip is this idea of how do we get people to really implement this and build the systems around this to make it work. So we're about to release an implementation manual, should be happening early next year, supporting people to think about how they might plan to deliver psychological interventions, how to adapt them, which is such a crucial part of making sure that they're effective, how to build a workforce, how to support a workforce to deliver them safely, and how to kind of evaluate the delivery of these interventions as well. Which brings me on to Equip, and I think brings me back to that idea of universal health coverage, that if we want to realize universal health coverage, we need to really support a workforce. We need to build a competent workforce. And there's a number of documents now supporting this idea of competency-based education as really being the approach that we should be taking if we're looking to support others to deliver support. So Equip is kind of looking at all these psychological interventions that we have and saying, this is great, we have a great evidence base behind it, but how can we be sure that in the real world, when we're implementing these things, that it actually be being delivered in the ways that they should be, so they're as effective as they were in the trials, but also, and I think crucially, that they're being delivered safely. And I think it's also answering a problem of benchmarking globally around the delivery of psychological interventions. That there isn't necessarily, particularly for scalable psychological interventions, particularly for non-specialists, any kind of benchmark or any kind of body overseeing the quality of that delivery. So how can we start to create some sort of benchmark? And I know that's also the work of WCCBT and many of the different members here, and it's something it's a reason why we're so keen to team up with you and why we're so keen to talk about these innovations really, and to get your feedback and to partner with you in terms of making these accessible and making them relevant to people as well. So EQUIP is really looking at how can we use competency assessment to ensure quality in the delivery of psychological interventions. This is broadened out somewhat now to think more broadly about just any sort of form of helping that requires an interaction. But for here, we'll think about psychological interventions. And the competency assessment tools really are quite similar to how we might run an OSCE if you're working in a university setting, for example. So it's running role play assessments with people and using these tools to assess people in those role plays. This is really targeted at trainers, supervisors, program managers across different sectors. So not just in health, but protection, education, and others, and people working in academic institutions. And as Dr. McGinn has said, this is a joint project by WHO and UNICEF. All of this is available on a free to use, free to sign up platform that I'll take you through briefly if I have the time. And really how we see EQUIP helping is that we're providing trainers, providing supervisors with a resource that really in quite a detailed way helps them to identify what a trainee's strengths might be, where that trainee might need further support, and then to support having discussions with that trainees on how they could improve, what they're doing well, how they can improve, and to help that trainer or supervisor to customize their training, their supervision, to ensure that it really meets the needs of their trainees. EQUIP and its suite of tools and resources has been developed across a number of years. I mean, the project's been running since 2018. We've trialed it in a number of different countries, and when rolling out a number of different psychological interventions. So the interventions here, we have PM Plus, which is a Problem Management Plus, which is a WHO intervention, but we also have non-WHO interventions, for example, trauma-focused CBT. So I think the point I'm trying to make here is that EQUIP number one was developed across a number of different contexts. This was actually done with a number of different partners as well. So the tools and the resources were built from people working in these contexts as well, and it can be used across a number of different interventions. And from this work that we've done since 2018, we've now have a reasonable amount of research kind of coming out that's essentially showing that, number one, if you're using EQUIP in your training, by which we mean you're assessing competency and providing feedback on that competency, what we're seeing is quite a sizable increase in helpful behaviors. And I think really crucially and quite uniquely for EQUIP, we're also seeing a reduction in unhelpful behaviors. And we have some emerging evidence as well that's showing that good supervisors are already quite good at seeing these helpful behaviors. They're quite good at spotting the good things that their trainees do. Potentially what we're not so good at is spotting the things that they don't do so well. That's the more challenging, it's the more challenge to have discussions on. And that's something we think EQUIP really has a unique approach to start to identify. Just coming back to the idea of competency, when we talk about competency in EQUIP, we're thinking very much about a definition whereby competency is the collection of someone's attitude, knowledge, and skills. And it's how the collection of those things are shown in observable behaviors when someone's performing an action. So someone is delivering an intervention. What are the behaviors that someone's showing when they're delivering that intervention that shows that they're competent? So we're really focused on those measurable, observable, concrete behaviors. As I've said, we're focused on the idea of using role plays to measure this. So setting up very structured, brief role plays, so as you can start to identify if these competencies exist or if more work is required. We're interested in role plays because they create quite a structured environment. So it's a controlled environment. So you can then actually see the competencies you want to measure, which isn't to say that you couldn't also use some of these tools that I'm going to show you in the real world as well. You can, so they could be used in live observations of cases. If you're doing supervision in that way, or you're running joint sessions or whatever it might be. But we think if we're building someone's competency, we also need to do the role plays as part of that as well. And this is an example of what one competency looks within a tool. So we have at the foundation of Equip, we have this competency assessment tool called ENACT, which is looking at the common therapeutic factors. So it's looking at things like our verbal, non-verbal communication, empathy, confidentiality, ability to manage risk, build rapport, involve family, etc., etc. So what you'll see in this kind of table in the middle are a number of different behaviors, what we call behavioral attributes, with boxes next to them. So you'd run a role play and you'd see, were any of these behaviors evident in that role play? And if they were, then you tick them off. And then depending on what you tick off gives you a sense of whether someone is displaying unhelpful or potentially harmful behaviors, which would mean that they get a level 1. Whether they're not showing any basic helping skills, but at least aren't showing any unhelpful behaviors, whether they're showing some basic helping skills, all of the basic helping skills, or maybe they're doing all the basic helping skills and some advanced skills as well. So we get a kind of, not only do we get some concrete kind of markers of what someone's doing, but we also kind of get a sense generally of how someone's developing as they're acquiring the different competencies required. So as I said, ENACT is what we would call a foundational helping skills tool. So it's looking at many of the things that we would see as potentially being necessary for delivering an effective intervention. We've kind of grouped these according to the skills that are required to engage someone, assess someone, and support someone. Then we also have a number of additional competency assessment tools. So we have other foundational helping competency tools for children and for working with groups. We have specific tools for interventions. These are mainly WHO interventions here. So the problem management plus intervention I've talked about. But also, and I think maybe more interesting for some of the attendees here would be our technique-specific competencies. So we have competency assessment tools for looking at ideas around cognitive restructuring, behavioral activation, motivational enhancement, etc. The idea being is that we would want to assess someone for their foundational helping competencies or the ones that we feel are relevant. So we group these based on the areas people might think are relevant, but these can be, you can pick and choose. And then the idea would be that based on the intervention that you want to deliver, the very specific intervention, you might want to add some additional competencies on top of that that are relevant to that intervention, whether it be a problem-solving intervention, a behavioral activation intervention, IPT, for example, or whatever it might be. Or maybe a collection of many of these, but these things can get quite complicated. So that would be the idea, that we think it's very necessary to do these foundational helping competencies, but then you can also tag on assessment of more specific competencies for specific interventions as well. And all of this is available on a website. I haven't got much time left, so I'm going to go through this very quickly. It's available on a free website that you have to sign up to use. This website has a kind of e-learning platform, helps you to understand the website, what we mean by competency-based education and assessment. It also has a number of different resources available for download, including the competency tools as PDFs in different languages, the role play scripts you might use to create these structured role plays. We have some videos to support learning. So in these videos, people are role playing, doing good, setting up a confidentiality agreement in an effective way or in an unhelpful way, so people can see the difference and can look at ratings. And then we have a collection of our publications, guide to how you might adapt and contextualize the tools, etc., etc. The key thing with the platform is that the competency assessment tool I've shown you is adapted to be an online version. The advantage of which is that it means that all the data, let's see if we've got it. So essentially, it's just like I've shown you with the with the paper tool, you see the competency we're looking at on the left. We see the different behaviors in the middle that we go through and tick. And then at the end, we submit this, and it saves that assessment. This can also be done on a mobile phone, on a tablet. It automatically resizes, and it can be used offline as well. The advantage of using this platform is that it then presents you with graphs automatically showing how your trainees are doing over time, over different assessment time points, and gives you summaries of that at the group level, helping to flag where there are any potentially harmful behaviors that you as a trainer might want to think about. Okay, I need to readapt my training so as I'm addressing, for example, issues around verbal communication. And then it also helps me to look at my individual trainees, and look at exactly what it is that they've been doing and provide very specific feedback. So here with Fiamma, I can look at exactly how she scored on these different competencies. So as I can say, for example, your verbal communication, you were fantastic at summarizing or paraphrasing, but you tended to ask too many suggestive questions. So we need to think about X and then move forward that way. And all of this can also be downloaded, I believe, as a CSV file. So you can download, you can then manipulate the data in any way that you want as well. And it is available at the moment in a few different languages. We keep adding languages to that as well. And this is all freely available, published on Creative Commons license. If anyone wants to take any of these materials, adapt any of these materials, we're more than happy for you to do so. We're also very happy to partner up with people and work with people who are interested in using or adapting any of these tools in any way they might like to do. Just quickly to finish up, so far we're seeing the platform itself was launched in March last year. We're seeing increasing use of it globally. We're seeing real global use of it. I've excluded the US here because many of the developers are in the US, so it kind of skews it somewhat. But I think we're at around 20,000 users, and the challenge has been like really translating that into active use. But we are now seeing people really using this, really integrating it in their trainings, particularly for in-service training. What we're really interested in is moving this into more pre-service training settings. We think if we're going to achieve our goals around universal health coverage, what we need to be working with is the people who are training the people who are delivering these interventions, who then go on to become the supervisors and trainers themselves in the future, and really start to bring into those settings very structured approaches to delivering competency-based education. And we're interested in how these tools could support that process. So we've started that process, for example, in Makerere University in Uganda, the University of West Indies, the American University of Cairo. That's still in development. We're seeing how they're using it in their courses with clinical psychologists, counseling psychologists, counselors. I think what's interesting is how they've actually found those more foundational helping competencies very useful. They found many of their trainees want to move on to the more specific, say, trauma-focused techniques and skills, but actually have neglected perhaps some of those more foundational skills, and using the tools as a real learning resource for them and to help them check their knowledge and check their practice. We also see real scope for using Equip in supervision, to structure supervision in many contexts where there isn't perhaps the expectation or the culture of supervision that might exist in other countries. I think also it's interesting for me as how perhaps some of the tools we have could be used alongside existing competency assessment tools that might be being used in CBT already. And we have used it in a number of different countries on both at kind of local NGO level, but also at kind of national rollout as well when working with ministries of health. So for example, in Zimbabwe, they're doing a big rollout of MHGAP training, which is essentially another WHO suite of resources to support mental health care in primary health, particularly resourcing primary healthcare doctors to be able to respond to the mental health needs of their population. And so we're looking at how EQIP can strengthen that training as part of its wide rollout in Zimbabwe. Interestingly, in Jamaica, UMatters is a text-based chat service for adolescents that uses volunteers from universities who are being trained in counselling or in psychology, and they're volunteers who almost use it as a placement. And we're using EQIP as a way of training those volunteers and ensuring they have the competency to respond accordingly, with all the additional complexity that responding in text brings, I guess. So moving forward, we're really looking at how we can bring EQIP more into specific interventions and training approaches. So we are releasing a number of different training manuals for the interventions that I talked to you about, and EQIP is being fully integrated in those. We're also due to release a manual on training in foundational helping skills, in which EQIP is fully integrated as well. We are interested in how experts in CBT might look at the treatment-specific tools that we have, and whether they have any ideas for their use or for their improvement as well. We really want to see, as I've said, how we could use some of this in advancing the competency of future generations of our specialists, particularly in terms of building healthcare systems. And we're looking to build sustainability of this through developing more of an expert user group that kind of takes EQIP out from being a centralized WHO held product to something that's owned much more broadly, and so it can be developed in that way as well. I just have a quick summary slide just to say we're really focused here on, with EQIP in particular, on reducing harm and improving quality of mental health services. EQIP is targeted at trainers, supervisors, program managers. We've developed a lot of our materials based on a systematic literature review, expert review of what's out there already. We've undergone a number of different trials of the materials as well. We're seeing that these resources can really deliver benefit for trainers and trainees, and that they can be applied very flexibly to people's existing trainings, existing courses as well. We're not talking here about changing curricula. We're talking about how we strengthen curriculum. And hopefully I haven't gone on too much, so I'll hand it back to you, Lata, and ask for any questions.
Thank you, James. That was terrific. And that was a great overview that you provided to us. I think there are a couple of questions that I'll ask. One is, an attendee has asked that they're curious about resources for working with children and parents, and are they included on the interventions website? Could you speak to that?
Yeah, I think it's an area where we recognize there still needs to be development. As I've said, the ease intervention is probably the first one we've released where we have an evidence base now. So that's very much focused more on adolescents, I guess, but also working with their caregivers. Yeah, that's where we're at. We are working on another intervention at the moment for younger children and their caregivers as well. But these things can take time to fully trial before we're happy to then release them.
Got it. Okay. And there's a question from Dr. Dobson, Keith Dobson, who is a past president of the WCCBT. He's asking, the EQIP program uses role plays and the assessment of overt behaviors, which is a highly defensible approach to competency assessment. In your opinion, or is there data, could the same ratings of overt behaviors be used to evaluate recordings or live observations of actual therapist client sessions?
Yeah, I think they could. So the tools that we have could certainly be used in that way. Absolutely. In terms of recordings, they could be used. You could also record role plays, for example, and then assess them that way. So these tools can be used remotely. In terms of live recordings, they can absolutely be used that way as well. As I said, we would say that should be done alongside the use of role plays. The role plays provide the controlled environment in which we definitely get to see the behaviors that we're looking for, that we're looking to assess.
Right.
And we make sure that happens through prompts, so that the trainee is prompted to, for example, talk about confidentiality, which won't necessarily happen, of course, in a live setting. So we would say, absolutely, they can be used that way. I think it can be very helpful to use that way. We've had feedback saying that they are very helpful to be used in live observations, or in recordings of sessions. But we'd also recommend strengthening that through role play practice as well.
Yeah, I think that's a great point, because the standardized role plays are inviting behaviors that you can assess, and not relying on the spontaneous occurrence of those behaviors. So you're structured in that way. So I think that's a great point. And it's a question from William Lieber. We're planning to start a non-specialist training program in a pediatric academic medical center. What is the best setting to use these tools, like primary care, community outpatient clinics, or can the competency assessment tools be used in any setting in which psychological interventions are being delivered by frontline workers?
I think I'd say they could be used in any setting. We've seen the use of them in many different settings. So I think I would say in any setting, really. Yeah.
Got it. Okay.
And we'd be more than happy to, if you want to send in thoughts via email to us, we'd be more than happy to kind of answer any questions you have on any more detail with that. For me to really get a sense of where it would best apply, I'd probably need to go into it in a bit more depth.
Got it. Okay, great. Another question from Golda Ginsberg. Are your materials applicable or adapted for school-based providers or personnel who might deliver mental health interventions?
They're not specifically adapted for that, but I think we'd see that they could be used by those people again. So it might require some adaptation, and we would leave that to people to do that adaptation. We have some guidance in the forthcoming implementation manual, which I can share in draft if anyone is interested in that can support that process of adaptation. I have known people to use these interventions in those settings as well, so we can also give advice on that. So we haven't had it specifically. We haven't specifically modeled in that way. We tend to create stuff that has the broadest use possible that can then be refined.
Got it. Thank you. Thanks. There's a question from Dr. Mark Reinecke. The equip approach seems sensible and systematic. How do ratings on role plays sync with other measures of fidelity?
Yeah, good question. Initially, for example, if we take an act, we developed an act as a tool. So that was developed very much by colleagues at the George Washington University, by Dr. Brandon Court. So I'd encourage you to look at some of his work. Essentially, what was done there was a review of a number of different tools that were already looking at fidelity and competency, and then refining those and looking at kind of crossover in those to come to the items that we have in that tool, then testing that in a number of different locations and testing it across with other measures as well. So it's performed very favorably. It's also shown to be reliable and very valid as a measure itself. I have some papers, or there should be some papers on the platform that should describe that process as well. So if you're interested, please reach out or take a look at the platform as well for more details.
Thank you. Thanks, James. Then another question here is, for doctoral trainees in clinical psychology, do you have any guidance regarding the expectation, preparation, and/or timeline if they're interested in pursuing a career in the WHO?
That's a tricky one. Expectation. I mean, can you say the question again? Sorry, I need to think through it
Do you
again.
need guidance regarding the expectations, the preparation, and/or the timeline if someone is interested in pursuing a career in the WHO?
Yeah, well, I'm a clinical psychologist, so I'm trying to sort of apply it to my own experience, and I don't know if I want to give guidance based on my own experience. I don't know. I I think in terms of developing a career in WHO, I'm not sure if I'm the best person to talk to. Essentially the structure is, I mean, I work related to headquarters in Geneva, but of course we have a number then of regional offices as well, and then country offices below that. So I think the guidance would probably be, depending on where you are, to reach out to country office teams and try and support those country office teams. So most of the development through WHO comes through really learning and understanding the system of WHO and working up through it in that way. So if I look at most of the people who are in very senior roles in WHO at kind of regional level or global level, they've tended to take that path. My path has been slightly different in that I've gone from practicing in the UK to then working internationally in humanitarian work, to working in NGOs and UN agencies as a kind of more of a technical expert, and then being brought on as a technical person, I guess, within specific projects. So which is to say, I think there's different routes depending on what you're looking for, whether you're looking for a full career in WHO, in which case I think you need to go through very formal routes, or if you're looking to be involved in some of the projects, which I think then a broad range of experience can be valid. Yeah. Again, more than happy to informally provide advice if people are interested, if they want to reach out.
Well, I think that brings us to the end, and I think that was very enlightening, James. Thank you for outlining sort of broadly the scope. I thought that was very helpful to hear the work that the WHO is doing in terms of psychological interventions in general, and then the EQUIP program. So yes, please reach out to Dr. Underhill if you have questions about that. If you would like to get involved with the WCCBT's work with the WHO, please do contact me. And we're so delighted to have you. Thank you so much. And thank you all for coming. And thank you to Rachel and ABCT for permitting the WCCBT to organize this webinar.
Thank you, everyone.
Thank you.